Hey everyone, we're going to finish up with our last set of lectures for the biostats section of the class. I'll be putting it all together. All right, so first thing you want to know is when to choose a particular statistical test, and we're going to look at how we can decide how to do that. So the first thing we're going to look at is if you're just looking at outcomes of continuous data from a Gaussian distribution. So keep in mind you're using parametric data or parametric test here. Some examples of continuous data that you could do these sort of tests on would be things like cholesterol plasma levels, or if you're looking at changes in blood pressure. And to test whether or not this data is coming from a Gaussian distribution would be to perform some Gaussian assumption tests. This is including looking at things like normality tests, or also looking at outliers, right? Outlier tests just telling us, are you likely to find a value this extreme just based on chance alone, things like that. If you're just describing one sample, so you're just looking for different ways you can describe it, looking at things like frequency distributions, you can look at sample means, you can look at the minimum and maximum value and then the range thereof. You can also use things like interquartile ranges, or 25th and 75th percentiles. You can also look at the standard deviation of the sample itself. So if you were to make inferences about this one population, so you say you took your sample, then applied that back to an entire population, basically what you're looking at is a one sample t-test, okay? This again will tell you, how does this sample compare to the actual population, and seeing if there's any real difference that's happening there. Not done super frequently, but you may see it done occasionally. More often what you see in a lot of like clinical trials and things like that are going to be two unmatched or unpaired groups being compared, and this is where you find your unpaired t-test. And if you were to match or pair those groups, this is where you get to a paired t-test, right? So these are only going to be for two groups when you're comparing. If you need three or more groups that are unpaired, this is where you do a one-way ANOVA followed by multiple comparisons tests. Or if you had a match test, you could do a repeated measures ANOVA followed by the same multiple comparisons test. Okay. If you needed to explain or predict one variable from another, you could do something like a simple linear regression. We didn't really talk about nonlinear regressions much, but it's very similar. Just depends on what type of relationship you have between the variables there. Again, this is just look for an explanation there. If you wanted to do, say one variable from several others, so you wanted to look at multiple inputs, you could do a multiple linear regression or multiple nonlinear regression there, right? So this can help you look for correlations. It can help you with explanations and predictions. Looking at continuous data from non-Gaussian distributions, or say or ranked data, again, you can look at things like 17 beta estradiol concentrations. If you're looking at, say, certain scores for prostate cancer, like a Likert scale, so looking at confidence in something, very high versus moderate, this can be good for that. So looking at just describing one sample, again, very similar things you can do, like frequency distributions. You can look at 25th and 75th percentiles. Here, you're not going to look at sample mean so much, but you're going to be looking more at the sample median, because we know this is the 50th percentile value. And then for making inferences about that population, we can use what we call a Wilcoxon rank sum test. We didn't really talk about that too much. This is very similar to just a one sample t-test. It is non-parametric. For comparing two unmatched tests is where you use a Mann-Whitney test. As we saw, that's kind of the cousin to the unpaired t-test. And then you can do a compared two matched groups, right? This would be a Wilcoxon matched pairs test, right? So again, keep these in mind. If I'm describing a type of non-Gaussian distributed, non-normal data, and what type of test would be most appropriate for that. And I'll let you know whether it's going to be Gaussian or not, and trying to make those determinations. If we were to look at survival times or time to an event, we can do things like using Kaplan-Meier survival curves, and probably the most common one you're going to see as far as curves go for time to a certain event. Median survival time, 5-year survival time, we talked all about those. And then when you're making inferences about that, you can use confidence intervals about the bands around the survival curve and kind of give you some information. Now, we didn't really talk too much about making comparisons between groups, but one of the things you can do is looking at the confidence intervals of median survival times, looking for if there's any overlap there. I wouldn't worry about these quite so much as I would about the other types of curves we actually looked at, and how you can actually describe those types of samples. When you're looking at binomial outcomes, so again, this is going to be something like a yes/no kind of thing, boy, girl, red or blue, those sorts of binomial outcomes. To describe them, you typically do a proportion, or basically what percentage of each of the outcomes are present there. And as far as making inferences about the population, you can just do a confidence interval of that proportion. And again, we didn't talk a lot about some of these other tests here, but some of these are kind of similar to some of the chi-square tests that we were looking at, because chi-square is again looking at yes/no type of binomial outcomes. So again, if we didn't really talk about it specifically in the lectures, I probably would not ask about it on the test, right? So I'm not going to ask you what a Fisher's test versus a McNemar's test, because we really didn't talk about it in great detail there. This is just more for your reference in case you ever run across this in the medical literature. You can kind of look back to say, well, what the heck is the Fisher's test used for? So going into the actual articles themselves, this will be important when we're actually looking at our journal club articles. So there's lots of reasons why you may want to read the literature. I'll kind of point out some of the more common ones you'll run into. Usually it's going to be to help edify yourself and how you can better treat your particular types of patients. So again, you have to be kind of judicious in what type of literature, because you can't consume it all. But if you're going into ortho, you'll probably end up reading a lot of ortho literature. If you're going into derm, you'll probably read a lot of derm literature. And so you can look for lots of kind of new and innovative things that are coming about in the literature. You can look for new health problems that are starting to pop up. So if you have certain types of issues that are coming about, I remember in the tox world, and this kind of includes a lot of the ortho literature, there were lots of problems coming about from patients who had metal on metal hip replacements or joint replacements. And basically what they were doing is that the metal and metal would kind of rub each other over time. You actually have leaching of metals like cobalt and things like that that was causing some neurotoxicity, right? So that's a new health problem we did not know about previously that was reported on the literature. You learn about new tests and for diagnosis and prognosis. So, what type of tests should we use to rule in or rule out certain diseases? You can read about new treatments or new types of programs for different diseases. Adverse effects of medical care. There's lots of reasons to read the literature, and so it's important to kind of pick out, when you're out there in the clinical world, like what you want to read and try to stay abreast of it, kind of what's pertinent to your practice, right? So for me, like I read a lot of the tox literature that comes out. I can't stay abreast of all of it, but especially if it happens to be peds related, or because we live in Florida, we have a lot of snake bites. I read a lot of the envenomation stuff that comes out, and new, antivenoms and things like that. So it's important to try to be judicious about what you read, because you're never going to get to all of it. So when you're looking at an article, typically you're going to find it gets broken down into several sections, the first of which being the abstract or the summary. And this is typically what you can read for free online if you don't have a subscription to that particular journal, or if you don't have like an affiliation with the university. This gives you the overview or the summary of the work. It'll highlight results and give you a general statement about kind of what they found and what their conclusions were. It's really, really important not just to read an abstract and take away any kind of evidence or anything away from this, right? This is just meant to let you know what's in the article and let you decide whether I should even read the article in the first place. Don't want to take a lot of conclusions away from this, because again, sometimes you'll find that the abstracts can be misleading. Sometimes they highlight only things that they want to show that were positive. Sometimes they'll hide a lot of things that were negative. So again, take it with a grain of salt if it's in the abstract. They'll have an introduction where they kind of give you a background of the problem or why they decided to research this in the first place. So these are usually good if you don't have a lot of background in the subject that they're talking about. This is good to get you kind of up to speed with where they're at with performing the study. Next, they'll do the methods. This will tell you what type of study design they're doing. It'll tell you how they selected their subjects, how they're going to measure their outcomes, and describe what kind of analytic techniques they're going to do. This is oftentimes where they'll talk about things like power calculations. They'll talk about the nitty-gritty basic details of how they did the study. Next, you'll find the results. This is where they tell you what happened. They'll give you tables, graphs. They'll tell you p-values, confidence intervals. All that stuff will show up in the results. Then they'll have discussions and the conclusions where they'll talk about their results. They'll talk about any limitations they may have had. So saying that, hey, we didn't find any statistically significant differences, but we had a small sample size, or X, Y, and Z happened. And so this is where they can kind of talk about their conclusions and say what they feel they think you can take away from this article. And then finally, they'll have their references. So again, the summary of the abstract is going to be a pretty concise statement, usually just a paragraph long, that tells you their goals or what the hypothesis of the study is going to be. And they'll tell you how the endeavor was taken in some limited detail. And then they'll give you the highlights of the results. Again, they usually are putting their best foot forward. So think about the abstract as kind of like a first date with somebody, where you don't really see all the gritty details, or you don't really know if they leave the toilet seat up, or if they have some kind of crazy idiosyncrasy that would lead you to not want to date them forever, because again, they're putting their best foot forward, right? So they're showing a lot of their positive results that they find there, and that's trying to entice you to read the rest of the article. Okay, they'll have any concluding thoughts there, and then you'll find that the structure of the abstracts changes from journal to journal. Usually, if you were to ever try to get published, they will give you very clear guidelines on how they want the abstracts to look. So that way, when you're in one particular journal, they typically look very similar from one article to another. The introduction is often designed to give you the background information on a topic and kind of get you up to speed, and to let you know why they wanted to do the study. Like, why is it important that this information be determined, and why is it important to you as a practitioner? Oftentimes it gives you a good review on the previous literature on the topic. So for instance, when I did my study on coral snake bites, we went through and looked at all the previous coral snake literature that was out there for those particular bites, and so we were able to see like what's been done, and now we know how to kind of proceed forward. And so again, a lot of this literature review can be very useful to kind of get you up to speed if you're not super educated on the subject to begin with. The methodology is going to be detailing how they determine what their patient population is going to be, how they selected those patients, did they randomize them, were they, were they paid, were they, random samples, what type of, patients were they pulling there. We'll talk about the study design, whether or not it was randomized, whether it was blinded, things like that will include there, and then how they collect the data, and then oftentimes what type of tests they're going to do. Most people skip this because this is, again, not the sexy part of the article. This is the nitty-gritty, all the details, but it's very, very important, because if they have any flaws here, this is directly going to influence their results. And so you can read the results and say, like, man, they found this really great change here. I'm going to change my whole practice for how I treat X, Y, and Z disease. When really, if their study was flawed to begin with, then you're going to take away some erroneous conclusions there. So be very, very careful in reading the methods. When we focus on our journal clubs, we're going to look a lot at the methodology, and so this is super important to read to make sure that the article actually even means a hill of beans. The results, typically you're going to find both in text, kind of highlighted the results, and they'll have a lot of tables, charts, graphs, and figures, things like that. And here, this is where it's important for the reader to kind of make their own assessment of the data. Look at the charts, look at the graphs, make sure that what they're telling you is significant, truly is, and you can oftentimes tell that based on confidence intervals. I mean, even though a lot of these journals are peer-reviewed, meaning that someone else who's an expert in that subject is reviewing it, sometimes they don't go through with a fine-tooth comb, and you can find things that they say, hey, this is significant, and you look at the data and it's like, well, no, it's not. So it's essential for you to be able to look at the data, make your own informed decision, and then read the results and the conclusions to make sure they back that up. Make sure you're coming to the same conclusions the authors are. In the discussion, you're going to have further analysis of results. They will also talk about how their study will sometimes compare to other studies that have been done to see if there's any differences. They'll talk about oversights, mistakes, limitations are really important. They should always talk about limitations in the study. And this is where they get most speculative. They'll say kind of like, here's what we feel we can take away from this article based on the results, but it's important that you also come to your own conclusions. Finally, you have the references or the bibliography. This is good. You can kind of see how good of a job the authors did and how exhaustive a job they did looking at the previous literature. This also can give you a pretty good way to move forward if you're trying to do your own research into a topic. I oftentimes will look at, if it's something I don't know a lot about, I will look at their bibliography and see if there's any other review articles or things like that I can read on to try to edify myself a little bit more. But again, should be included with every article. If they're not there, that's pretty odd, and I would probably have to look at something with a lot more critical eye if they weren't there. So how you approach an article, basically use selective reading. Like, try to determine which journals you want to read with some consistency, which articles of particular interest, right? So, even though as a toxicologist, I don't read every single article that comes out in clinical toxicology, but I read things that are very pertinent to my work, right? So I read a lot of things about envenomations. Being here in Florida, we have a huge problem with opioids. I read stuff on opioids. I read stuff on pediatrics. And so you have to be very judicious with your time and what you're going to be reading. Usually you can just go through, scan a table of contents, and select any articles you want to look at in greater details. And then basically scan the article, try to get a quick overview, look over some of the graphs and tables, and then you're going to try to gauge the structure of the article, right? So again, don't just look at the abstract and say, hey, this looks good, I'm going to start changing my practice based on this. You never want to do that. You need to kind of scan it over, see what the methods are, see if everything kind of makes sense, and then you kind of go in through with a more fine-tooth comb. As I mentioned, it's really important to concentrate on that methods section because this is where you can really find a lot of the flaws in the study or find some of the limitations thereof. So usually I tend to focus on this and make sure that the information that's being presented is really only as sound as the actual study design was in the first place. So they may say, hey, we found this really great difference, but if the study was designed poorly, or if it wasn't even designed to look at that in the first place, then you should kind of look at it with a little bit more of a critical eye. So looking more specifically at study design and what you'll be reading in the methods. Basically, there's going to be several different types of studies we can deal with, looking at both descriptive and explanatory studies, and we'll look at these in more detail as we go forward. But these are going to be good, a good table to kind of go back and so that we can kind of compare and contrast different types of articles. So descriptive studies are basically just that. They describe things, they record events, observations, or activities. They don't provide detailed explanations for the cause of a disease, or they don't really offer evidence into ways to treat things, but they're good because they can at least give you an idea of kind of what's the current problem or what has been the trends and problems by describing what's already occurred. An example could be something like the incidence of Kaposi sarcoma in HIV patients or something like that. Usually they are easy to do, they're pretty cheap to perform, and they can be a good starting point for more kind of elaborate studies. Basically, they'll give you an idea of like, okay, well, this is the scope of the problem. Now, what kind of study can we design to get more into detail? What's the best way to treat it? Or which patients are more likely to get it? Things like that. Explanatory studies oftentimes are making comparisons between groups. They attempt to give you kind of more insight in either to the etiology of a disease, kind of what risk factors are more likely to cause you to get a disease, find better treatments for that, and we'll find those can either be experimental or observational. Experimental includes things like controlled trials, clinical trials, and these are going to be active intervention of the investigator. These are going to be much more resource intensive, expensive, time consuming, but basically what we're starting at is we're beginning with our study population. Start here with the study population. We design usually an experimental or intervention. We'll kind of allocate patients into either group. We have a control group, which basically they're serving as our comparator group. And then you'll find, something like, measurement of whatever change you have, whether it be change in blood pressure, whether it be disease outcomes, things like that, and either plus or minus, either get it or they don't, plus or minus. And so again, you're starting at the beginning and going forward in time when you're looking at these experimental studies. And so then you can compare to see what are the differences here between your experimental group and the control group. So that would be considered a controlled trial. With observational studies, oftentimes you're making comparisons to examine and try to explain medical mysteries. Why is it that some people get lung cancer? And looking at some of the influence that different risk factors can have on that. And so here we see the researchers are going to be the bystanders. Typically, they're just kind of gathering data about subjects. They're not actually making any actual interventions in these cases. So you can find that the three main types they're going to do are called case control studies. They'll do follow-up studies and then cross-sectional studies. I've kind of alluded to some of these already in previous sections. With the case control design, essentially what we're starting is the outcome, right? So we're beginning with people that have the disease versus our controls, who are people without disease. And remember, we said that oftentimes we're going to have a lot of control patients, usually say like a 4-to-1 ratio, could be more, could be less, but you typically have multiple controls, and compare those with people with the disease, have the cases, kind of go back to that cholera vaccine example we talked about previously. And so by controlling that, you're trying to control for kind of other confounders, differences in age, differences in gender, differences in lots of different factors, by getting similar controls without the disease and matching those with people with the actual disease. So you're starting here at the present and then looking back in the past to see what type of risk factors led them to be more likely to come up with that disease or not. So in the case of the cholera case, we're looking at cases that with people with cholera versus those that did not. Again, matching similar controls to the cases and then looking back to see who was vaccinated versus who wasn't. Okay, and again, a case in this example will be a subject who already has the outcome of interest, and we look back to see what risk factors are more prevalent for each of those groups. Follow-up design would be where you start with people who have not yet experienced the outcome, and this is oftentimes referred to as a cohort study. And again, we're not going to be starting off with any, we're not actually having any intervention that's already happening here. We're basically just observing things still, so it's still observatory studies. Basically here you start with the study population. Notice this is going to be prospective because you're going forward in time. We were looking at that case control study that was retrospective because we were looking backwards in time. Here we start with our study population. You're only using people who are free of disease to begin with, right? If they already have the outcome, that they're excluded because they're not really too interesting to us. But what we can do is say, like, okay, well, what are the the effects of smoking on the incidence of lung cancer? So you start with people who don't have lung cancer. You can group them into people who say smoke versus people who don't smoke, and then you look to see what their disease outcome is. So you look at the incidence of lung cancer in the smoker group versus the incidence of lung cancer in the non-smoking group, and then you can make some inferences about what that effect, that risk factor had on disease outcome. You can also do a cross-sectional study where this kind of is a blend of a case control and a follow-up or a cohort study. And basically you're beginning with the population of the cohort. You kind of make a simultaneous assessment of outcomes, descriptive features, and other kind of potential indicators or potential predictors. And then you kind of do a slice in time or a prevalence survey where basically you're kind of looking at one specific time to see like what that prevalence is in that group. These are not done nearly as commonly as I see with either case control or follow-up or cohort studies, but would be one other type you might see done out there in the literature. So some questions to consider, is the design descriptive or explanatory effort, right? So if the author is trying to detail their experience with cases or their practices or treatments, or are they making comparisons in hopes of establishing, why do people get a certain disease, or are they evaluating some sort of intervention that they're making? If comparisons are being made, is the observer looking at the course of events, or are they maybe creating an experiment by assigning subjects to receive a pill, an exercise program, some sort of like health literature or education? And then if the design is observational, are the patients who already have a disease or outcomes compared with people who are unaffected, and they're looking for pre-existing characteristics, or are we going to identify people with their risk factors and then see if they develop the outcome? So you're going to be able to, as you look at more literature, you're going to get a better idea for what type of study we're dealing with, and we'll look at various examples of this in our actual journal club next time we meet in person. Okay, so let's see if we can actually look at some of the actual data and apply some interpretation to it based on sensitivity, specificity, and predictive value. So we have a study here. This is done back in 1973, and they were looking at bacteremia. They found that it was most frequent in children when 7 to 12 months old. There's a very significant p-value there. Associated with a white blood cell count of 20,000 or more. It's also significant in a temperature 39.4 degrees C or higher. Okay, so again, just looking at p-values, it's important not just to be seduced by those. Like, let's make sure that when we interpret this stuff, we not only look at the statistical significance, but also the clinical significance of any of these results here. So, as you can see, some of the factors that they were associating with bacteremia in febrile pediatric outpatients. You see that it looked at different age groups here, so they found that different patients, different age groups, and they had different positive cultures. They found the most here in 7 to 12 month old patients out of total cultures here. So you can see the totals that they had, and the percent that actually ended up being positive. Okay, you can also look here to see the different temperatures. You can find that 39.4 or higher tended to be associated with patients who actually did have positive cultures here, or the bacteremia, and then also looking at the white blood cell counts and tend to be associated. So these are all the things that they associated or had a significant p-value as being associated with having bacteremia, or in this case, it was defined as having a positive culture in these febrile pediatric patients. And so when looking at our sensitivity, specificity, and predictive value, you can see how we can calculate sensitivity based off of the actually having a positive test with the disease actually present. So that's our true positives divided by all of the patients who had the actual disease, right? So this is going to include both our true positives and our false negatives here. So this is going to be our sensitivity. So again, out of all the people who had disease, how many of them do we actually detect, right? So that gives us our sensitivity. On the flip side of that, with specificity, this is our ability to detect true negatives. So again, we're looking at people who had a negative test and the disease was absent, or this would be D in this case, and this is going to be divided by B plus D. So these are all the people who did not have the test, or I'm sorry, did not have the disease, but they may have had positive and negative tests here. So again, this would be false positives. This would be true negatives here. Okay. So again, you're going to see what the specificity is by looking at all the true negatives divided by all the people who did not have the disease. And then looking at our predictive value, you can see that's going to be equaling the true positives divided by all the people who end up testing positive. So again, both people who did and did not have the disease are true positives plus your false positives. So this tells you how good a predictive value this test will have. And so, for instance, when they're looking at applying this information, for instance, looking at temperature, right? So they're looking at patients who had a temperature greater than 39.4 versus those that had less than 39.4. They found that those that had a positive blood culture, they're 16, right? Here, patients who did not have a temperature, so the test result in this case would be considered to be negative. You'd find that they had positive cultures in 6 of those cases. So again, this would be all the people who had positive blood cultures, versus here you find our negatives. So you can see that as far as sensitivity goes, for patients who had a fever greater than 39.4, we'll find that you had a sensitivity of about 73% in order to detect the total number of people that actually had blood cultures, or that would have a positive blood culture. So you found some people with a positive blood culture that did not have a fever that high. So again, this would not be 100% sensitive in detecting all those true positives. So again, only about 73% sensitivity. As far as specificity goes, or the ability to detect those true negatives, we found that we had a total of 252 people, or children in this case, that did not have a high fever, greater than 39.4. Out of those people who, the total number of people who did not have actual disease, so only a specificity of 55%. So again, not super great in order to detect people who did not have the actual, it's difficult to predict who would actually have a positive blood culture based off strictly on these temperatures. So again, the reason for that is, and again, looking at the predictive value, only about 7%, that makes sense because people can have fevers for lots of other reasons than just bacteremia. They can have a fever for having pneumonia or UTI. So because of that, you can determine that just having a high fever is not going to be super predictive for having bacteremia, right? You can combine this and look at the same information with white blood cells. There's lots of reasons for people to have a high white blood cell count other than just bacteremia. So there's lots of people who would end up having high white blood cell counts, but they didn't have the disease. They had it for other reasons. And so we can see here it's not super sensitive. Specificity is a little bit higher, so that way you said that, hey, if someone really does have bacteremia as evidenced by a positive blood culture, if they come up negative for that, their chances are that they are going to have a high white blood cell count essentially. And then looking at the predictive value, we can see here only about 12%. So again, not super great as far as sensitivity goes. This is a lot better for specificity though. So again, someone who is going to have a positive blood culture is unlikely to have a low white blood cell count. They're probably going to have something at least over 20,000 in this case. Okay, so there's a better ability to really detect those true negatives. So again, temperature to diagnose bacteremia will properly identify 73% of patients who have positive blood cultures. So again, sensitivity will properly identify 55% of patients without the disease. Okay, and then only 7% predictive value of all children with temperatures above 39.4 will have positive blood culture. So not super good predictive value. It's because again, patients can have a temperature greater than 39.4 for various other reasons than just having bacteremia. Again, looking at the white blood cell count, we said it has a specificity of 88% and sensitivity only 29%, right? So lots of other reasons kids could have high white blood cell counts. So now let's see how we can factor in prevalence in looking at our sensitivities and specificities. So again, pre-test or the prior probability is going to be that prevalence of a disease in the study population that we're interested in. So whether it be IV drug abusers or the general population, whoever happens to be. And then we'll see when we're talking about post-tests or posterior probability, this is going to be the same as the predictive value. So you can kind of see how these are all calculated here. Again, sensitivity going to be the number of true positives that we get divided by the total number of people who had the disease in the first place. Specificity going to be the true negatives divided by the total people that did not have the disease. And the prevalence would be the number of people who actually had the disease out of the entire population. So you can see how this is going to be 100 because you had a total of 100 people with the disease divided by a total of 2,000 people you're having in your sample. And then so you can see the predictive value here ends up being the total number of true positives divided by everyone who ended up being positive. So again, 90 plus 190 equals 280 here. And so again, here in this case, we'd have a predictive value, say 32%. Here's an example of how looking at prevalence and some of the sensitivity and specificity of these tests can be have a big impact on society. Here you can see that there was a policy proposed by some state legislatures to require mandatory premarital HIV testing. And so they wanted to estimate what they thought the benefit of doing this sort of premarital screening program would be. Right, and so they were looking here at the expected enzyme immunoassay results as of the tests that they were performing in 1 year if they're doing the premarital screening program. Basically what they were doing is that they knew the prevalence of HIV in the population to begin with, and they were looking at what their sensitivity, specificity, and also the predictive value was going to be in actually finding some of these results. So essentially, looking at the actual prevalence, they found that they had 1348 out of this 3.8 million roughly number of people they had here. So again, prevalence only 0.035%. So very, very low prevalence of HIV in the population. But when you look at that, you look to see how many people actually tested positive for having the disease. You saw that 8,973 tested positive, right? That's way, way higher than what the actual prevalence was in the first rate based on our population, kind of that pre-test probability that we had, or that prevalence that we knew based on previous studies, right? So yeah, this can be a problem because we're going to be identifying a lot of people as HIV positive when they're really not, and that's kind of some bad news to receive if you truly don't have the disease in the first place. It can lead to a lot of surely a lot of marital strife, I might imagine, premarital strife, I guess in this case, but also a lot of impact when you're testing a lot of people who don't have the disease to begin with. So again, the test has a high level of sensitivity and specificity, but with a very low prevalence. So that still means that with the post-test probability ends up at around 15%. So that means that for every 1,300 individuals who you correctly identify the HIV, there's going to be over 7,600 false positives, right? That's a lot of false positives. And so when the authors employed a second stage to the screening, and they submitted all the positive tests, so an enzyme immunoassay, or enzyme linked immunoassay, those positive individuals for a confirmatory Western blot test, which is kind of the gold standard. That test itself had a sensitivity of 92%, specificity 95% here. We still found that you would still have 380 people that remain falsely positive per year. Okay, so this means it's better to screen a population based on identified risk factors to get a better yield. So if you start off with a group of people who have a higher prevalence to begin with, so instead of doing everyone who's getting married, which you would think has a pretty low HIV prevalence in the first place, maybe starting out people who have a history of IV drug abuse, or starting out with people who are more likely to have the disease in question, because that's going to make your yields a heck of a lot better and also lead to less unnecessary testing, save money, save a lot of heartache. It's all going to be better if you start out with a high prevalence population, or you can at least screen people for that to begin with. So despite kind of looking at the evidence, they decided to implement this in Illinois for a short period of time. And they found that after 6 months, they had basically 8 of 70,000 marriage license applicants ended up being seropositive. That was even lower than what they would have expected with a frequency of 11 out of 70,000. They found that for every positive applicant, it cost roughly $312,000. So again, not super cost effective. There are probably better ways to screen for those patients to begin with in order to find those HIV positive patients. So one other thing we can look at when interpreting these kind of results is the likelihood ratio, which again is the ability to say, like, if a person has a positive test result, what is the actual likelihood that they really have the disease in question? So in this case, or here you'd calculate a sensitivity divided by 1 minus your specificity. So in this case would be your true positives divided by or your true positive rate divided by that false positive rate, essentially. And so that gives you a good number to compare kind of the discriminatory capabilities of different tests. So for instance, this is used very frequently to try to determine, like, how can you rule certain things in or out, certain diseases or diagnoses in these patients more effectively, right? Because again, you want to have the quickest, cheapest, easiest way to determine if someone has the disease, so you can decide if they need surgery, if they need a certain treatment, if they need to be admitted, discharge, whatever it happens to be. So this is a case for looking at appendicitis. Essentially what they did was they looked at several different tests. They compare their sensitivity and specificity and see what the likelihood ratio of them, if they had one of these signs or symptoms, the likelihood they were going to actually have the disease in question. And so there's certain things that kind of make physiologic sense. So for instance, right lower quadrant pain, that is usually pretty specific to appendicitis. And so I saw a very high likelihood ratio. A bigger number here means they're more likely to have the disease in question, right? Certain other things are not super specific for having the actual disease. So for instance, nausea and vomiting. Notice here, likelihood ratio not super great for that, right? That means that, there's lots of other reasons people can have nausea and vomiting than just appendicitis. And so if someone presents with nausea vomiting, you're not going to look at them and be like, oh, you must have appendicitis. But if they were to have, say, right lower quadrant pain plus internal rigidity or rebound tenderness, these things would lead you more likely to think that it's appendicitis you're dealing with versus just simple, say, gastroenteritis. There can be some difficulties when you're using likelihood ratio. Basically, the test discriminating ability does not really tell the whole story. So in this case, if you're looking at migration of pain versus abdominal rigidity, both of them have a pretty reasonable discriminatory power. Again, if you have a positive test for each of these, they're 3.6 times more likely to be found in patients with appendicitis versus those without. But you see that migration occurs in a higher number of patients, higher proportions, so 75% of patients, versus rigidity in 32%. So again, the sensitivity is a lot different here, but rigidity has pretty good specificity and rarely occurs in patients without appendicitis. So you kind of have to take all of these things into account when you're evaluating your patients. So this is how you come up with a lot of these kind of risk scores, these tests that kind of give you a better idea of, like, what's the likelihood they really have this kind of test here. Again, these two signs are going to be equally helpful in distinguishing appendicitis from non-appendicitis when they're present, but if they're not there, then it can be very difficult to see. If they're not present, it's one of those things where you can't necessarily rule out appendicitis. So you have to kind of take the whole story into account when evaluating these likelihood ratios. Okay, the next thing we're going to look at is interpreting risk being reported in studies. So oftentimes clinicians are faced with lots of different types of implicit risk each day, and you have to kind of constantly balance, say, what is the benefit of, say, giving my patient treatment versus holding off of treatment, or what are potential liabilities that could occur, both yourself and the patient as well. And so what we oftentimes do in the literature is to use risk to reveal, information about the etiology of diseases or to demonstrate the effectiveness of interventions. One of the big things you have to know here is when we're dealing with the denominator, or the number of people who may be at risk for a given outcome, or whatever we're dealing with there as far as the population goes. We use relative risk. It's going to be a measure of kind of the strength of an association between a particular exposure or, say, a risk factor, or we could be looking at an intervention and an outcome. So again, what we're going to find is that the larger the risk or the rate ratio we see here, the stronger an association we're going to be able to pull away from this. So here's something we can do to interpret risk. And so this is an example where we're looking at the rates of meningococcal disease in college students. Essentially what you're seeing here is that you're differentiating patients based on different characteristics. Our numerator here is going to be the number of cases that are reported for each of these groups. Again, here we can see that this is what we're taking from the CDC. We can then use our population as our denominator, and this is taken from the Department of Education in this example. So here, notice the population is times 1 million, so this would be 14.6 million. Basically, what you see is that you would divide for students that are 18 to 23 years of age, non-students, divide 211 by 14.6 million, and you get this rate of 1.4. In this case, what they're doing is rates per 100,000. Oftentimes, these rates are so small. So imagine 211 cases within 14.6 million. The actual rate is very, very small. So to make that closer to an actual whole number, they'll oftentimes say, you know, rates per 100,000 people or per 10,000. And so in this case, they did 100,000. They also include the confidence interval, how sure they are of what the actual range would be if you apply this back to the whole population. So here we can see that 211 divided by 14.6 million, you see here that these patients tend to be at an increased risk for having meningococcal disease. Okay, so 1.4, they have 40% increased risk versus that general population of all these patients from the Department of Education, right? Or as reported from that Department of Education. Looking at all college students, they tend to have a decreased risk here. So if you look at college students as a group, they tend to have a decreased risk. Looking at freshmen, you saw, as you might imagine, freshmen coming in being exposed to all kinds of new bugs from different people. They tend to be at a higher risk there. And then also looking at them living in dormitories, also much higher risk here. And then looking at freshmen in dormitories, you can see kind of a combined effect here where, you know, they're 5.1 times higher risk for getting meningococcal disease versus some of these other groups. So these are good because they can kind of tell you who is at highest risk for developing a certain kind of disease. And so this is where, you know, you can see, okay, well, obviously freshmen in dormitories tend to be the highest risk. If you're going to implement some sort of health intervention, this might be the group that would benefit most from this. A lot of times you can see that things like, you know, male versus female, white versus black may not have as big of an impact here. Sometimes you'll find that the sample size may not be high enough to tell you a whole lot of information, but you can see that, you know, certainly you can find some associations here. Here's another example where they were looking at physical activity in women and looking at coronary risk. So you can see here the quintile group for these different women based on their self-reported physical activity. So again, the lowest quintile versus the highest here, and basically looking at, you know, different risk factors. So are they currently smoking? You know, here are the different percentages: history, hypertension, all of this. And then you can look at things like the number of coronary events they have. And so basically you can see what the relative risk would be between the different groups. So again, women having the lowest amount of self-reported exercise would be kind of your baseline value, and you can compare the women that exercise more to see, you know, what other effects this would have. So you can see the relative risk of and again, they used an age-adjusted multivariate analysis. They used all these different inputs to control for to see specifically what this one effect of different exercise amounts had on the relative risk of coronary vascular disease. You can see here that obviously more exercise equaled a bigger amount of protection. Here where they actually adjusted for age alone, you saw that, and again, you see this association kind of holds out true when you do both the multivariate and just age-adjusted. Sometimes you can do what we call a risk ratio, and so this would be a case of women who are taking estrogen plus progestin therapy or placebo, and this was done in a very large study called the Women's Health Initiative. It was a very important study that was done. But basically what they were looking at was their risk for things like coronary heart disease or stroke, things like that, if women who were taking oral contraceptives or just estrogen plus progestin based products versus placebo. And so what you see is the risk of a certain outcome. So here you see coronary heart disease 164, divide that by your 122, you see a relative risk ratio of 1.29. So there's a 29% increased risk for coronary heart disease, and you can apply that back to, say, you know, per 10,000 people per year, an increased number of 7 people developing coronary heart disease. You can do that for all of these, including things like, you know, stroke, pulmonary embolism. So these are some of the risks that we know can occur with taking estrogen and progestin drugs. Breast cancer as well, again, an increased risk here. Versus some things you might actually have protective effects. So here you see colorectal cancer or hip fracture, and a lot of these make physiologic sense, you know, when based on what we know from physiology and what we'll learn later on in pharmacology. But just looking at a global index, so total number of outcomes, you can see here pretty large increase in the total number of outcomes that would occur there per 10,000 women per year. So here's an example of using odds ratios to help us out to determine risks for certain outcomes. So here we can see we're looking at risk factors for meningococcal disease. This is going to be something you see a lot in case control studies where we're looking at odds ratios, because again, we're not looking at incidence of new disease because these sort of things are done retrospectively. These tend to be looking specifically at odds, looking at prevalence. And so what you can see is that we have our case patients here. Here I have an N of 50 versus the controls. And again, typically with a case control study, you're usually applying multiple controls to the case patients. And what you can see is you get an odds ratio to determine which one of these factors are going to have basically an increased effect or decreased effect on developing meningococcal disease. Again, when looking at these, when you're doing odds ratios, if the confidence interval includes 1, then you know that's going to be a non-significant value. And again, the p-values can kind of back you up on this. So know that a freshman in the dormitory tends to have a higher odds ratio, so 3 times higher odds of developing meningococcal disease, even though it has a decently wide confidence interval there. Freshman in dormitories, very similar, 3.7. So higher odds of developing meningococcal disease. And again, but neither of these contain 1, so these are going to be significant. Versus something like, say, active smoking. I see here that there's the odds ratio, even though it's 1.5, it would appear that smoking would increase your odds of developing meningococcal disease because this includes 1. So it goes anywhere between 0.5 to 4. You can see this would be non-significant here. So here's an example where you can look at both relative risk and attributable risk. Here, what we're seeing is that we're looking at death rates of people, and again, this is per 100,000 people in the population, and we're comparing deaths from lung cancer and deaths from coronary heart disease, and we're looking at heavy smokers versus non-smokers. And so basically what we can do for relative risk is just divide the risk of one versus the other. So here, if you were to divide the lung cancer deaths divided for heavy smokers divided by the number of people dying from lung cancer they were non-smokers, you see here a 32 times increased risk of dying due to lung cancer if you smoke, right? So that's a relative risk between people who smoke versus those that don't. So you can see certainly, and there's no p-values here and no confidence intervals, so you couldn't say necessarily if this was significant or not, but this would be the calculated relative risk. Similarly, for coronary heart disease, we can see here that heavy smokers 516 divided by the non-smokers 361, you'd have a 1.4 or a 40% increased risk of death if you were a smoker due to coronary heart disease. So we can see that the association is a lot stronger with lung cancer and smoking versus coronary heart disease. There's still an association with heavy smoking and coronary heart disease death, but not as high as you would see with lung cancer. You can also find just what the attributable risk is, or just the number of people who have that increased risk, the number of increased deaths, specifically just due to heavy smoking. Because again, if these heavy smokers were not smokers, you know, they would have a very similar risk as the non-smokers, obviously. And so we can call this attributable risk and just subtract one versus the other. So say 223 minus 7. The attributable risk of death due to lung cancer for heavy smokers is 216 per 100,000 people in the population. For coronary heart disease, here you can see 516 minus 361, or 155 deaths that are attributable specifically to the effect of smoking there. Again, can't tell if these are significant based off the information provided, but assuming there's confidence intervals and p-values, you could be able to determine that. You can also figure out number needed to treat, and so this is important when you're trying to see, like, well, how effective is a therapy going to be? How many people do I need to treat with this intervention in order for it to cause a difference, right? And so what you can find here is that we're looking at patients with new vertebral fractures and postmenopausal women who received either a placebo or raloxifene, which is a selective estrogen receptor modulator. We'll talk about that when we get to pharmacology, but they had 2 different doses that they were comparing here. So again, placebo, raloxifene 60 a day, or raloxifene 120 milligrams a day. So they looked at a number of different women. So again, here you can see the sample sizes are pretty close together. The number of women in each of these groups had a greater than 1 vertebral fracture. You know, the differences here, and then the relative risk they're able to determine. And notice, because the placebo is your comparator group, they're able to come up with some confidence intervals here. And so basically, here you saw that there was a 50% decreased risk, relative risk, in order for patients who are taking 60 milligrams of raloxifene a day to have vertebral fracture, versus here is again very similar with the 120 milligrams. So no, significant difference here between these 2 groups. You'd say, either dose would be effective versus placebo alone. And so what you can come up with is basically the number needed to treat. So how many women with low bone density would I need to treat in order to prevent 1 vertebral fracture? And so basically you can calculate it out, and it would come out to be basically 46 women need to treat with 60 milligrams of raloxifene a day to prevent 1 vertebral fracture. And so the question is that cost effective? Is that, does that make sense, based on side effects of the drug? There's a lot more that comes into whether or not this is a good therapy or not, but it kind of gives you an idea of how many patients do you have to treat in order to get some benefit. If you were to look at women who had a previous vertebral fracture, so they already had a prevalent, they were coming in with a vertebral fracture, here you can see that the number of women they treated, the women after that time period that developed another vertebral fracture in these cases, and so again here the relative risk again is still both of these are significant. You found that there's a bigger association, they have bigger benefit of raloxifene 120, and so you can see here they have a lower number needed to treat. So I need to treat 10 women who already had low bone density plus a previous vertebral fracture. You treat 10 of them in order to get the benefit of preventing one more fracture. So next we're going to look at some of the causes for some of the things we'll see in the studies. You know, what are some things that can affect our results that we find? And so confounding is going to be the biggest thing we're going to be looking at here. So confounding occurs when factors that relate to both our characteristic that we're experimenting with, or the one that's under scrutiny, and the outcome appear as kind of competing explanations. So for instance, if you were to look at the rate of cigar smoking for bald men compared with the controls. So we're looking at people who had baldness. So yes, were cases, no, people had their hair, and then looking at cigar smoking. Okay, so based on what you would look at relative odds, is it would appear that patients who are smoking tend to have an increased risk of baldness. And so you think, well, does that make physiologic sense? Not a ton, especially with odds that high. So again, you don't see every single person every man who smokes a cigar goes bald, right? It's not the case. So there could be a confounder here that are showing, causing us to see these significant results that we're not really accounting for. So if you were to look at the average age of the cases in that previous one, you could also see that the average age of controls was 24. So again, when you were to pull out and specifically look at the men who were 40 to 45 who are already at an increased risk for being bald anyway, you can see, because again, as you might imagine, a lot of 24-year-olds probably aren't smoking a ton of cigars versus older men probably are. You can look to see if you just look at 40 to 45-year-olds, you can see here that the relative risk actually calculates out to be 0.85. So just looking at this specific age group, so when you take out that particular younger skewed population, it tends to appear that cigar smoking actually might be protective, right? Of course, we don't know if that's actually true or not. You have to do bigger studies, but when you kind of account for these different confounders, you may find wildly different results. And this is what the investigators really need to be upfront about, and either showing how they controlled for these things, or if they didn't, they need to list out, hey, these could be potential confounders. So again, looking at our characteristic factor, the cause we're looking at, we want to see an apparent relationship with a specific disease or outcome. But again, you could have a confounder that could be affecting what the actual relationship is. You have to always keep confounders in mind and make sure that investigators are reporting on these. Here's an example of looking at potential confounders. So if you were to look at, say, mean daily sugar consumption for patients with heart disease versus those that had no heart disease or control subjects, we can see here that in our group, and again, it's a small sample sizes, but we had 20 patients with heart disease, 25 that did not, and looking at their mean sugar consumption. So it would appear, and again, without any statistical tests, you can't derive any actual conclusions, but it would appear there's an association between heart disease and sugar consumption. The question is, what if we had other factors that were confounding this? And so one of the things they wanted to find out was if smoking could be a potential confounder here. If you were to look at patients who, say, had heart disease who are smokers versus non-smokers, you can still see here there's a difference between sugar consumption, and then looking at control subjects, smokers versus non-smokers here. Both you can find changes in the sugar consumption. So the thing is, you can actually control for the smoking to determine specifically what effect of heart disease or sugar consumption is on the incidence of heart disease between these two groups, both in smokers and in the non-smokers here. Basically what they found was that the relationship between sugar consumption and heart disease is in fact confounded by smoking, right? But if you were to hold that effect of smoking constant, you still find that in both cases, both smokers and non-smokers, increased sugar consumption was associated with more heart disease, okay? So again, you can control for these things, but in fact, both of them are related to heart disease, right? And that makes kind of physiologic sense based on what we know about diabetes and smoking and all of that. Going back to this example of women with various levels of physical activity, again, this is a good example where we can use a multivariate analysis to try to control for many of the confounding factors here. So again, when we're looking at physical activity protects women against heart disease, whether this is true or not, there's lots of different things that can affect this. So both age and then other factors. So typically people who exercise more tend to not smoke as much, or they maybe use multivitamins more or consume less alcohol. So you need to control for all of these to see what kind of effects they're going to have have. And this is where multivariate analysis can kind of control for all of them just to find out what effect exercise is going to have on heart disease on these women. And so here you notice at the very bottom they have age adjusted, so they're just looking at age controlling for that. And with multivariate, you can control for things like smoking, hypertension, diabetes, all of these different factors. Dose response is also another thing to consider. Again, a lot of times it's not so much, when you're looking at drug studies, were they either on the drug or off the drug? Oftentimes dose can be important as well. And so sometimes you'll see these broken down to where here we're looking at menopausal estrogen use in women who have endometrial cancer versus the controls, and then looking at their average daily dose. So again, breaking out the controls here on whether they used estrogen at different doses and seeing what relative risk that has on causing endometrial cancer. And you can see here, the larger the doses tend to, or larger doses here between 0.6 and 1.25 or greater tend to be a higher association than if they're taking less than half a milligram. So the questions to consider when reading the literature is, have the authors actually addressed the possibility that there could be chances or bias or confounding factors that are kind of responsible for the effects they're observing? If they've identified the confounders, is the list pretty reasonable? Are there any known risks that they have not included that you know about? Or could some unmeasured confounders be playing a role here? So that's always important questions to ask when evaluating the literature and looking for the effects of confounders or bias. So also have the steps been taken to control for confounding, was matching employed when they did the study design was great, or they have multivariable techniques or control tables that have been employed in the analysis to let you see that yes, they have control for these confounders. And then if they supply evidence that potentially causal factors are confounded, what additional evidence is there to suggest any causality? Does evidence of the strength of the association or biological plausibility or consistency, does any of that make a convincing case? So what they're saying actually makes sense based on what your knowledge is of the disease processes or just the biological plausibility of a lot of this stuff. You don't always want to take the author's word for everything. Make sure you're using your critical thinking cap when evaluating this stuff. So anyway, that's the last question. This is the end of the section material for the actual biostatistics test. So if you have any questions, please let me know, and I'll see you guys in class.